So we're going to have a short time for questions. We're going to adjourn no later than 12, and we have to be back here at 12:30 because of some time constraints of our speaker.
Well, thanks very much to our speakers. So we do have 10 minutes for questions, and so I just ask people to line up at the mic, and again, just to remind you to please introduce yourself before your question.
Hi, Paul Jarvis, March Times. I want to ask Wendy Parmet, you talked about the importance of research on legal, and I would say policy interventions. In working with the states and state public health agencies, we found it nearly impossible to find timely and research that could be supported as policies were rolling out. So we couldn't do comparative studies about this is how one state implemented this, how another state implemented it. We went to the NIH and they said that's not really what we do. So two questions, how do we accomplish that? And the other question is, how good is the science? Because these are such complex systems. Is the science up to studying it and informing us about policy interventions?
Thank you. It's an important. Thank you. It's an important question. There has been a lot of progress made in the last several years in developing the methodologies and supporting the Robert Wood Johnson Foundation for many years supported a group. Richard's been involved with it as a public health law research program that really tried to develop a methodology for studying regulatory impact. One of the challenges has been, it is hard to do for the reasons you have said. There's a lot of complexity. And secondly, there has been a shortage of funding for this kind of research. And it's one of the things, again, that I would suggest that we really need to give more thought to, because we impose a lot of regulatory changes without having a good understanding of what their ecological impact would be. The last point I would make is, there is, and this gets less to FDA, but obviously there are some advantages from a methodological perspective in this way, a research perspective, for allowing local and state innovations, because it's obviously easier to research when we see what different states are doing, when we have a single national intervention coming. We've got time comparisons, but it's harder. But it definitely need more research in this area without question, and more funding for the research.
Can I add something, Karen?
Sure, absolutely.
Thanks. I think it depends a little bit upon what policy and at what level, but we actually know a fair amount about different FDA actions, particularly risk communications. So we performed a systematic review looking at this, and there are several lessons that can be drawn from that, and I'm happy to share those with the committee. The other thing I'll say is that in the opioid space, the most effective policy change that I'm aware of is at least with respect to utilization, is the hydrocodone upscheduling. And I can't recall if I mentioned, but that was after a decade of disagreement between the FDA and DEA. And what we've seen from rigorous policy analyses of the effect of the upscheduling of hydrocodone from Schedule 3 to Schedule 2 is substantial clinical and public health significant, policy significant reductions in hydrocodone sales as a result. So there's lots more outcomes that you'd be interested in, I'm sure, what happened with substitutes, what was the effects in terms of long-term opioid use disorders and the like, but the bottom line is that we do know something about the ways that policies can and can't affect utilization and other outcomes.
The question I have is really to the FDA, and what are they doing in the setting of the Sentinel Initiative around this? Because that goes across the country. There's 178 million covered lives. And so I'm wondering what the FDA is doing in the Sentinel Initiative setting.
Hortensia, do you want to?
Oh, thank you. Hortensia Amado, University of Southern California. I have two questions, if it's okay. Hi, Wendy. It's good to see you again. I had a question for you. You mentioned the principle of public health as a legal norm. And so my question was, what are the either legal or other types of tools for enforcing infractions or correcting infractions to threats to population health? And I'm obviously interested in specifically as it relates to the issue we're discussing today?
Hi, that's great to see you. And that's a very complicated, tough question because the enforcement mechanisms are really very much situationally specific. So when I use the term legal norm, I'm using it very carefully to not, again, and I think I mentioned in my remarks, to say not clear and, enforceable duty. So I don't think, for example, that someone who is harmed by the opioid epidemic is probably not going to have a judicially enforceable case against the FDA for its failure to act, right? There are all kinds of barriers. So this is a much more subtle and complex way of thinking about how courts and legal actors interpret the obligation of the government to enforce public health. We see it clearly on the other side of the coin, so to speak, in terms of great deference is usually given to public health authorities, including FDA, when they try to look at population-based approaches. There are specific instances and cases and situations where it's enforceable, but I can't give you a single answer because it becomes very situationally specific.
I was thinking also in terms of pharmaceutical companies that if we're to take some of the information presented before really were or played a significant role in the impetus of this epidemic. So I'm wondering whether, within that norm that you mentioned, how their role fits in.
The role of the pharmaceutical company?
In promoting some of the information we heard earlier about promoting some of the opiate-based pain medications in terms of, beyond what label or...
I guess the way I would describe this is I don't necessarily think of the norm as being imposed on private actors like pharmaceutical companies. What I do think I'm suggesting is that I think the FDA should assert and have some confidence about the robustness of its ability. And that includes, something we've been talked about in terms of regulating marketing and things. And it's an argument that the FDA should be able to, in its regulatory capacity, consider and impose upon and regulate those private entities from a population perspective.
Thank you. And I just had a quick question, Diana. Hi. So I was very interested in what you presented in terms of education, prescriber education. Are there any studies that have gone beyond knowledge and actually looked at how education has impacted prescription, behavior on physicians or prescribing behavior?
To my knowledge, and this is not unique to opioids, there are all these physician trainings available all the time that are never tested to see how well they work, or at least if they are, that information is not being made public. And sometimes these training, they can be an online 5-minute training, which makes it even more frightening when doctors don't finish them. But these are often very perfunctory trainings that you check off the box. We require training, and generally no information at all, not just about what they learn, but whether it affects what they do.
So, sorry, Doug, I saw you stood up for a second there. Did you want to address something on the Sentinel question?
Longer conversation. I'll talk to Bruce and to Frank maybe.
Okay, or the committee might want to know. I just wanted to comment. I think the interventions need to take place at systems levels and not at individual physician levels. In our clinic, we approached it as a group and developed pain contracts and policies in an opiate review committee, and we got pain consultants to come in. So this is not something that the medical community and the pharmaceutical industry are responsible here, and we need systems within medical care systems to handle this. I think the FDA is very important here, and I agree with many of the things Caleb said, but I think his graph shows that the FDA can't intervene effectively on an epidemic caused by the medical community and the pharmaceutical industry, that they're powerless to do that. And we need systems approaches within medical communities, clinics, HMOs, to manage this. And it's not going to be, the education. You're right on about the CME training.
Mark Schumacher, UCSF, a committee member. But getting back to this same point, in the committee, in a general understanding the authority of the FDA. I mean, we had a presentation from Caleb that the FDA has in its own power currently the authorization to do certain interventions, yet the FDA in their statement of task is asking us for direction for authority to act. You laid out, Caleb, a plan of the labeling, how that has an impact on marketing, and that could have a tremendous impact. So that as the background, does the FDA need additional authorization power, or are they already empowered to act at this point in any of these current regulatory issues we've just discussed?
Well, I just heard that there of 13,000 employees, 1,000 are counsel or lawyers at the FDA. So I'm not going to try to go there. I would just say that, that it seems to me, in my naive or sort of educated layperson read, that they do have the authority. And I certainly think that you can make the case that the scope of harms and risks from these products far exceeds, and the questionable risk-benefit balance far exceeds those in many other settings where they are employing similarly restrictive policies.
Any other final comments? Okay. Thank you all very much.
Sorry, Aaron, just one real quick question. We should probably ask the committee to revisit their statement of work about the authorities. If there's been some misunderstanding that we were asking for clarity about additional authorities, then I think it is exactly that, a misunderstanding. I don't remember that being a part of the things we were seeking for help from you. I mean, I think we have a reasonably clear understanding of our authorities. I think they've been described in some fashion this morning. They're a bit more complicated, but I think it was more about this how to understand the nature of this epidemic, how to approach decision making in this epidemic for the FDA from a populational perspective, in addition to this individual benefits and risks. And I think that was more the focus of it, and less so on the authorities. But if we need to, we could talk some more.
Okay, we're adjourned.